Hello, I'm Tom Lucier from the Royal Brompton Hospital, and I'm pleased to present the paper of the week together with Brian Holliday, also from Imperial College and the Royal Brompton Hospital. Welcome, Brian.
Thanks very much for having me.
So let's look at the paper we want to discuss this time. It's a preprint, really. That's why it looks not very chic yet, but it's a very interesting paper. It's called Genetic and Phenotypic Landscape of Peripartum Cardiomyopathy. It's a lot of authors from many different institutions because, of course, as you all know, this is a relatively rare disease, and therefore one has to work together to end up with a cohort that is appropriate to reach any kind of conclusion. So, Brian, let's start with the question: What did they look at exactly?
So I think over the last 5-10 years, we're getting a greater in-depth understanding of what peripartum cardiomyopathy is, and I think we've understood that at least for a proportion of women with peripartum cardiomyopathy, there is a genetic susceptibility to developing it. And I think with the genetic kind of hypothesis, we also have other hypotheses. There seems to be an overlap with hypertension and preeclampsia. And also there seems to be this story about prolactin, so a specific cleaved fragment of prolactin which may promote oxidative stress and play a role in the pathophysiology of it. And there's been lots of interest, of course, with bromocriptine trying to reduce prolactin production as a treatment for it. So this paper really builds from the previous paper by James Ware and colleagues in the New England Journal of Medicine a few years ago. That showed that about 15% of women with peripartum cardiomyopathy carried a truncating variant in Titin. And this paper really looks at a greater number of women, really to dig a little bit deeper, see if there's other genetic variants other than Titin amongst these women, and then tries to tease out whether they have a different phenotype to women who don't carry these genetic variants.
So let's look at the population they were looking at. So here we have the characteristics. Yes. Mm-hmm.
Yeah, so a big cohort of patients with a relatively rare disease. So 469 participants, mainly from American centers, but also there are some from Japan, Israel, and Denmark as well. So I think the things that I noted from this, most of all, were that 41% of participants in the US were of African descent. We know that peripartum cardiomyopathy probably is more common amongst women of African descent, and this really came out from those figures too. And also that a large number of these women present with gestational hypertension or preeclampsia, again supporting a bit of an overlap between these conditions.
Right. Yeah. Mm-hmm. Good. So let's look at the genetics of it, because that was, of course, the main topic of the paper, wasn't it?
Yeah, so they looked at over 60 genes amongst these women that are associated with dilated cardiomyopathy typically, and then they compared the frequency of rare truncating variants in these genes amongst the women with peripartum cardiomyopathy compared to very large control cohorts. So either a control cohort that's been produced in Geisinger in Pennsylvania or in the NOMAD collaboration. So they found that there were excesses of truncating variants in 4 different DCM genes. So the table on the right, so there are 49 women with truncating variants in Titin, and there's also an excess of truncating variants in filament C, desmoplakin, and BAG3. So, 4 of the most commonly associated genes with dilated cardiomyopathy.
Yes.
And the association with the non-Titin variants is a new finding compared to previous studies.
So how did they compare to those who didn't have the Titin variant?
Yeah, so the frequency of BAG3 in the peripartum cohort was 0.21%, so pretty low. Desmoplakin again 1.3%, and filamin C again about 1%. So small numbers of women were carrying these variants, but whenever we compared them to large control cohorts, it was still in excess. And perhaps these figures are not too far away from the figures that we'd expect whenever we look at the prevalence of these variants in people with DCM. And then the truncating variants in Titin occurred in around 10% of women. So again, pretty similar to DCM cohorts.
Right. So let's move on to the next aspect of it. I mean, how do they differ compared to those who didn't have it?
So I think this is another novel aspect of the paper, in that we haven't really had too much data about how the phenotype of these patients may differ compared to those patients who don't have these genetic variants. And I think quite interestingly, the women who carried truncating variants in Titin were just as likely to present at any time during pregnancy. So perhaps one hypothesis before the study was that these women were going to present earlier in pregnancy because they already have a pre-existing cardiomyopathy. But indeed, that didn't seem to be the case. And indeed, these women seem to get gestational hypertension or preeclampsia just as common as women who didn't carry the variants. And interestingly, in terms of outcome, were just as likely to recover and didn't have an excess in terms of adverse events over follow-up.
But the ejection fraction was different, was it, in the two groups?
Yes, so those patients who carried the truncating variants in Titin did seem to have a slightly lower ejection fraction at presentation, but then almost 70% of them had recovered on follow-up. So at presentation they may be slightly more severe, but they seem to recover just as commonly and don't have an excess of adverse events clearly.
So these variants are basically risk factors for peripartum cardiomyopathy, aren't they? So
Yeah.
it's sort of a disposition or a trigger for it, but the basic presentation is very similar, although for the Titin variant, it seems to be a bit more severe.
Yeah, absolutely. I think they're found in 10% of women with peripartum, and in a small number of healthy controls, so less than 1% of healthy individuals in the population. So I think the carriage of these variants increases your risk of developing heart failure at different times during your life associated with different insults, whether that's chemotherapy, drinking too much alcohol, or because of the hemodynamic stresses of pregnancy.
So what is the main factor of the stress related to pregnancy? Is it just the increase in stroke in stroke volume, in cardiac output, or what is it?
I think that's a good question. Is it simply just a hemodynamic stress associated with increased stroke volume? Is it that some women develop hypertension and that unmasks it? And then in a proportion, could this prolactin hypothesis be at play, and could oxidative stress be driving it? And these are all questions we don't have good answers for at the moment.
And how long did it take to recover for both groups?
So I think the recovery was taken, or they were taken as not as recovered if they hadn't recovered by 12 months.
All right, exactly. So it can take a while to recover, indeed, huh?
Yeah.
So what is the long-term prognosis or outcomes of these patients? I would guess that they may actually have or may present with heart failure at any other condition, be it that, as you mentioned, that they have an infection, a cancer, or even spontaneously over time.
Yes, so I think we need, better data about their chances of having a relapse in their heart failure over time. We don't have that type of data at the moment, but clearly it's important in trying to decide what therapy these women still need to be on for the rest of their life.
So what are the characteristics of tight cardiomyopathy? We published actually a paper in the European Heart Journal some time ago, and they found that there is a bit more fibrosis, and they also had some sort of arrhythmia risk with VT. Maybe not as much as other variants, but it was clearly there. What is the phenotype of these patients once they do have cardiomyopathy?
So I think there's been a fair bit published, and perhaps it's, there's a little bit of discordance between studies. I don't think there's a clear signal across multiple studies that these patients have an adverse arrhythmia risk. Certainly the paper from the Maastricht group in the European Heart Journal suggested perhaps arrhythmia was slightly more common. That wasn't seen in other cohorts, and I think we need more data and longer term follow-up. There's been suggestion from some papers that perhaps these patients are more likely to recover, and if we catch it early and unload them with medications, perhaps they recover more commonly than other patients. But again, I think we need longer data, we need better data, and we need to see what happens with these patients in the long term.
Yeah, but the treatment of these patients is essentially the same, isn't it? And
yeah, absolutely.
What was used, and they didn't describe what they used to treat those patients with variants of any cardiomyopathy gene, did they?
No, so that wasn't well described in this cohort. I think the treatment of tight cardiomyopathy is the same as any other type of
Right.
TCM at the moment, although there is hope that we will develop targeted therapies, perhaps targeting the sarcomere in the future, that may be more effective in these types of patients.
All right. Is prolactin playing any role in this context, do you think?
I think the prolactin hypothesis is compelling, and I think the question is whether this is just a proportion of women or a subset of women where this plays a role, or whether it is more common than just a small number. Whether there's geographical differences, whether it's more common in the geographical hotspots like South Africa and Haiti.
Yeah.
I think it is possible to measure this specific cleaved segment of prolactin, but it's not easy to do that. So that's not a commonly available thing. But I think it's certainly something we'll hear more about.
Very good. Okay, that's a very stimulating new finding, and we have to really in the future put more emphasis on the genetics of patients with cardiomyopathies as we learn more about their impact of these variants on the presentation and in the future also on long-term outcomes. So thank you very much, Brian.
Thank you.